Okay, so for Alzheimer's, there's a lot of things that go wrong in Alzheimer's, but there's only one main thing that we tend to address in treating Alzheimer's disease. And Alzheimer's, when you get Alzheimer's, you kind of have like a decrease. Okay. So you have a decrease in serotonin, you have a decrease in acetylcholine, and you have a decrease in norepinephrine. And in addition to all the other abnormalities that you'll learn about, like the amyloid plaques, neurofibrillary tangles, but those are not things that you can really address with drugs, as far as we know. So the main treatment for Alzheimer's is going to be this. They're going to try to address this problem of the acetylcholine. And since they have less acetylcholine type of neurons, so their production of acetylcholine is going to be less than usual. And the main treatment for Alzheimer's is going to be cholinesterase inhibitors. So what you do is cholinesterase inhibitor. And so cholinesterase inhibitor kind of addresses this problem. And in addition to that, later on in the disease process, so mild to moderate or earlier on in the disease, they'll do cholinesterase inhibitors. And when it gets more severe, they actually add in this other drug, memantine, and this is a Nmda antagonist. So I want to go over this one just a little bit because it wasn't very intuitive to me why we would use this drug. But as it turns out, when you have way too much NMDA receptor being stimulated, it eventually will cause apoptosis of the neuron. So to prevent those neuron damage, that's why they're using this NMDA antagonist. So prevent apoptosis.
For like glutamine neurons?
Yeah, it's like overstimulation of those neurons. Yeah. So this is also something that they worry about with like prolonged seizures, for example. They're also worried about that if you have prolonged seizures, you really should take care of it because overstimulation of a neuron could cause the NMDA receptors can cause apoptosis. And this is something you'll learn later on in neuro. And then, so that's with the mantidine. And then the cholinesterase inhibitors, those include, these mostly you just need to recognize the that these drugs belong in this group. And and that's about it for Alzheimer's. So these are Alzheimer's. Okay, and then I'm gonna spend like maybe 5 minutes just talking about ADHD.
I have a quick question.
Yeah.
So methylphenidate is like a further progression of disease that's research history that?
Yeah. So this is for like more severe.
Okay.
Yeah, and then this is like mild, moderate. You start by using cholinesterase inhibitors. And the rest of it is more like treating other problems that they may have, like depression, which you already learned about in first block, depression or anxiety, just comorbid symptoms. Same thing with Huntington's, like the main thing is, oh, sorry, I didn't talk about Huntington's yet. Yeah, so for Alzheimer, the main thing is basically the cholinesterase inhibitor. In the very severe, you use memantine. And then if they have depression as well, then you will use whatever drug it is for depression. So that's about it for Alzheimer's. And Huntington treatment, so I should have probably talked about Huntington's first, but Huntington we already kind of talked about before that it's too much movement. And too much movement we said was associated with too much or too little dopamine. Too much dopamine. And for Huntington's, this is what we're addressing, the too much dopamine part. To do so, the main treatment is actually going to be like those indirect acting dopamine antagonists. So they actually use things like reserpine and tetrabenazine. And these are VMAT inhibitors. So this is the idea is that kind of preventing dopamine from being released in the first place. So they're not transported into those vesicles and they're not getting released. So the main treatment for Huntington's would be these two VMAT inhibitors. And dopamine blockers are also used, so haloperidol and things like that could also be used. So that would be like dopamine blocker, also used, for example, haloperidol. For Huntington's? No, Huntington's mostly some part of the basal ganglia is not working, so there's not enough of the indirect pathway to decrease movement in the first place. Yeah. So to reverse that, you would want to bring down the amount of dopamine, so to hopefully that'll make their movements more normal. And then Huntington's, there's also comorbidities. So Huntington's, it's not only just that part of the brain involving movements. They could also end up with like depressions and other symptoms. So to treat those, it would be the same idea as the antidepressants if they have depression. So things like that.
So you do an SSRI?
Yeah, you could. Yeah. Things like SSRIs and whatever other symptoms they might have. Okay, and then the last one we're going to talk about is ADHD. And ADHD, the problem is like too much excitement, too much stimulation, but for some reason the treatment is actually like a CNS stimulant. It's a little counterintuitive to me, and I still haven't really gotten a very good explanation as to why.
There is no explanation.
So for some reason, this is like, the problem is too much stimulation, but you're giving them more stimulant. But it seems to work. Okay, and then most of these are also the indirect acting ones. So the two main ones that you use is methylphenidate and atomoxetine. So methylphenidate is a dopamine and norepinephrine reuptake inhibitor. And then atomoxetine is it's a norepinephrine reuptake. It's just a norepinephrine reuptake inhibitor. So the problem with the atomoxetine is it also increased suicide ideations. And if those don't work, they also target alpha 2. So they will give you alpha 2 agonist. And so also alpha 2 agonist. And alpha 2 agonists, generally you don't want to start off using alpha 2 agonists. You would try to use these first, because alpha 2 agonists will give you sedation. So they kind of look very subdued, very sleepy. So to avoid that side effect, they typically give these 2 drugs first, and then if that doesn't work, then they give alpha 2 agonist. And I don't want to write all the names and stuff right now, but I'll have a chart with all the stuff, all the drugs that you need to know. So these are the basic, so these are the treatments for Alzheimer, Huntington's, and ADHD. Are there any questions?
Why would you give an alpha 2 agonist?
So alpha 2 agonist is the one that's presynaptic. So if you, and it's kind of has like a negative feedback action on the postsynaptic. So if you give alpha 2 agonist, that kind of decreases the amount of norepinephrine stimulation. Again, I don't understand why some of these treatments are the way they are and why they actually work, but it seems to work. So I'm gonna pause this.